Hi, this is Martha Mims from the Dan L. Duncan Cancer Center at Baylor College of Medicine, and I'm pleased to be able to share my talk today as part of impacting multiple myeloma patients in African American communities. Today, we're going to talk about financial impact in multiple myeloma. So, multiple myeloma in the United States. In 2021, it's estimated that there will be 34,920 new myeloma cases diagnosed, with 12,410 deaths expected due to multiple myeloma. The trends in incidence rates have really a lot to say about what's going on in multiple myeloma. From 1975, the total cases in men were about 6 per 100,000, but now, closer to 2021, there are about 9 to 9.4 cases per 100,000. Similarly, the incidence rates in women have risen from about 4 per 100,000 in the population to closer to 6 per 100,000. So interestingly, the incidence of multiple myeloma has really increased over the past 30 to 40 years. Now, in 2021, the survival rate at 5 years is about 55% as compared to 29% in 1995. And in 2018, it was estimated that there were close to 150,000 people in the United States living with myeloma, up from about 83,000 only 10 years ago in 2011. So while the incidence rates have gone up in multiple myeloma, the death rates have gone down, and that large gap leaves us with many more people living in the United States with multiple myeloma. So what does that improved survival cost? Well, we all know that this is not a curable malignancy. And at present, the median survival is somewhere around 7 to 8 years, although that is a moving target. But drug costs have risen very dramatically, and the multiple drug regimens that we now use are quite expensive. I want to give a few examples of the cost of drugs for a month of therapy. For lenalidomide, if you use 21 of 28-day regimen, it's about $17,490. For bortezomib, 4 doses in a month, in a patient with a body surface area of about 2, cost around $1,900. Whereas its partner, carfilzomib, for 6 doses in the first month of therapy, cost about $12,000, so nearly 6 times as much. Pomalidomide, an oral drug we often use, at the 4 milligram dose costs about $19,000 for a 21-day cycle. And daratumumab, the monoclonal antibody we have really begun to use in the last 2 years, cost about $25,000 in the first month for a 70 kilogram person. The CAR T-cell therapy cost about $419,000 for a single dose. And belantamab mafodotin costs $19,000 for a dose. The 2 drugs we use most for bone-protected agents, denosumab, cost about $2,500 for a month of therapy, whereas zoledronic acid cost only about $33. So there are vast differences in the cost of the drugs that we use both to treat myeloma and to protect bone in myeloma. So what does this mean by regimen? So if you look at Medicare and patient cost in the first line therapy for the regimen we call VRD, bortezomib, lenalidomide, dexamethasone, the annual cost to Medicare, and this would be Medicare Part B medical benefits, is about $33,000, with estimated patient medical care expenses around $6,700, with an annual cost to Medicare on the pharmacy benefit side, or Medicare Part D, of $231,000. So the annual cost to Medicare for that regimen, adding both Part B Medicare and Part D Medicare is around $248,000, with the annual patient out-of-pocket expenses for the regimen around $16,000. Looking at the identical numbers for daratumumab, lenalidomide, and dexamethasone, the annual cost to Medicare, summing both Medicare Part B and Part D, is around $368,000, with the annual out-of-pocket expenses for the regimen to a patient around $46,000. For KRD, which is carfilzomib lenalidomide dex, the annual cost to Medicare for the regimen is around $250,000, with annual out-of-pocket expenses for the patient around $16,000. In the second line, the combination of bortezomib dex cost Medicare around $165,000 and out-of-pocket to the patient around $41,000. If you look at the cost of ide-cel, our CAR T-cell therapy, the annual cost to Medicare is about $345,000, with the annual out-of-pocket for the patient around $86,000. And then some of the regimens used later in therapy, including belantamab, cost about $43,000 annually to Medicare, around $10,000 for the patient, and selinexor, which is mostly Medicare Part D payable, cost about $110,000, which is about $9,700 out-of-pocket expenses for the patient. So you can see that the cost of these regimens varies quite a bit, and the annual cost to the patient is actually quite high. So what does this mean in terms of survival cost? It's not really all just the drugs. So if you look at the total all-cause healthcare cost for myeloma patients in the year 2000, it was somewhere around $3,000. And now, moving up closer to 2015, it was around $15,000. So multiple myeloma treatment-related drug costs in the year 2000 were around $500, and now closer to 2021, the cost is somewhere around $4,000 per month. So you can see the tremendous increase just in this century in the cost of drugs and the overall cost of care for patients. So what are the patients experiencing then? Well, there are several financial toxicity studies out there in multiple myeloma. Probably the biggest one is called the Cancer Experience Registry. And this was a study conducted between July of 2013 and 14, a collaborative study involving the cancer support community and the Leukemia Lymphoma Society. And this study surveyed 266 patients about financial costs and distress. About half of the patients were women, and the median age was around 64. Quite concerning is that 91% of the patients in this study were white, and the median time from diagnosis was about 4.5 years. The patients were pretty well distributed in terms of annual income, with about 30% less than $40,000, around 35% between $40,000 and $79,000, and about 30% more than $80,000 in annual income per year. And their out-of-pocket expenses were estimated to be around $100 a month for 73%, and 48% spent $250 or more per month, 22% spent more than $500. So in terms of paying for treatment, 32% of these patients reported depleting their savings, 22% borrowed against or used money from retirement, 35% reported cutting their grocery expenses, 35% used pharmaceutical assistance programs, and about 5% skimped by skipping medication doses. In terms of getting help, 56% reported their healthcare team talked to them about resources related to getting financial help or financial counseling, which is concerning that only half of the patients got any kind of financial counseling. 28% reported their healthcare team ever discussed the impact of multiple myeloma on personal finances. 82% reported that financial counseling would be quite a bit or very much helpful to them. And 81% were willing to receive financial assistance for medication, 77% for the cost of treatment, 55% wanted to receive financial help for transportation, and nearly 50% for living expenses. So in terms of quality of life and finances, there was a linear increase in overall distress with a very strong p-value. And the risk for depression, also with a strong p-value, showed that increased distress and depression occurred when there was a greater monthly increment in out-of-pocket costs, adjusting for income, until the monthly out-of-pocket costs exceeded $1,000 a month. 32% reported experiencing high levels of intrusive ideation about the financial cost of their myeloma care. 33% reported they were often or always upset about money and the cost of care. And 47% were either moderately, seriously, or very seriously concerned about health insurance or money worries. There was a second financial toxicity study of myeloma conducted in August of 2014 to January of 2015, and this included 100 patients who had received at least 3 months of treatment, and this came out of the University of Pennsylvania. All patients in this study were insured, and all the Medicare patients had supplemental insurance, and their median income was somewhere between $60,000 and $79,000. 70% of these patients had college education. In this study, 59% of patients reported treatment costs were more than they had expected. 71% had at least a minor financial burden. 36% applied for financial assistance. 46% had used savings to pay for treatment, and 21% had to borrow money to pay for treatment. Overall, the study demonstrated that a younger age, single status, longer duration of disease, and lower income was associated with a higher financial burden. There was a final financial toxicity study in myeloma on clinical trials, and this was a US FDA pooled analysis of clinical trial patients. And in these studies, drugs would generally be paid for by the sponsor, but the increased clinic visits, the missed work, and the travel costs associated with participating in clinical trials were not. This study involved more than 5,000 patients who answered the EORTC Quality of Life questionnaire. The mean age in this study of patients was 65, with about half being male. 85% of these patients were white, and 6% were enrolled in the United States. About a third had financial toxicity at baseline. 69% showed stable financial toxicity at 3 and 6 months. 14% showed the financial toxicity to be worse at 3 and 6 months. And interestingly, the myeloma response rate was about 69% in those with any financial toxicity at baseline, and 72% of those with no financial toxicity at baseline. But this study, there was missing data for insurance status, socioeconomic status, and other health determinants. And note that almost all of the patients in these studies were outside of the United States. I think what you could hear from the studies I discussed is that the majority of the financial toxicity studies which are available out there really do not include African American patients. And in the study from the FDA, most of the patients were outside of the US. The study from Penn, a large number of these, in fact, all the patients were insured. So there were no uninsured patients included there. And in almost all the studies, very few African Americans were included. So I think with regard to financial toxicity, things might look different in this demographic. And I think
it's fair to say that more research is probably needed to understand how toxicity impacts Black multiple myeloma patients.
So what can we do as physicians to help our patients? Well, I think it's very important for us to educate ourselves about the outcomes of regimens and to prescribe the regimen with the lowest cost alternative for our patients, which means we have to understand not only the clinical consequences of choosing a regimen, but the financial consequences of choosing a regimen. We really have to talk to our patients and address treatment affordability with our patients. We really need to be involved with helping to develop national guidelines that incorporate not only outcome, but cost. We need to prescribe generic drugs when available, especially when the outcomes of the treatments are very equivalent to higher cost regimens. We need to conduct strategic trials to investigate ways to cost reduce our regimens. This might mean looking at alternative dosing or limiting the length of treatment. And we really need to access pharmaceutical assistance programs for our patients. And we need to address clinical trials with our African American patients. As you could see in that final study, these patients really had less financial toxicity, even though they perhaps needed to come to the clinic more often. So overall, I think there are many things we can do as physicians to address the financial toxicity of our regimens, but it involves us addressing the cost directly with our patients and being part of the national conversation about the cost of treating patients. Thank you for listening today, and I would urge all of us to go out and help our patients with multiple myeloma. Thank you.